Yeah, hi everybody. Our topic is mental health today, and this is Dr. Dracy from the Lewis and Clark Behavioral Health Services here in Yankton. And you have the handouts, so maybe we'll just get started. Is there anything I forgot there? I'm going to run the slideshow.
Not to confuse anybody with that doctor title, it's a psychologist. And mostly what I'm doing is I'm just going to review mental illness things. I've got this NAMI presentation that was put out by New Jersey. It was for law enforcement, but it's a pretty good review and covers most of the things I think we'll need to talk about. There's some stuff that's not terribly relevant in this situation. We'll skip over that fairly quickly. And mostly I want folks to ask questions as we go along. And so the title is, what is mental illness? What is, what it isn't, how to deal with people who have it.
All right.
So basically today we're going to talk about a number of different mental illnesses, and in the field of mental illness we group things up into psychotic disorders, mood disorders, anxiety disorders. There are also developmental disabilities like mental retardation, Asperger's disorder. Folks in NAMI, they kind of sort out some of the developmental stuff as opposed to mental illness because of the treatment and stereotypes and other kinds of things. But I think you folks probably work with individuals with both developmental disabilities and mental illness. We have a long history of blaming parents for mental health problems, blaming people for mental health problems. We're getting a better understanding all of the time about mental illness, and we recognize that most of the time it is not due to bad parenting. I also tell people, though, mental illness, the field of psychology and psychiatry, are probably the most inexact of our sciences. Most of the time, things that fall in the realm of mental illness, you can't do a blood test, you can't do a urinalysis of them. Once we do kind of get so that there are biological markers, then the neuroscientists take credit for them and they go out of our field. And so dealing with mental illness can be kind of difficult in actually assessing, making sure you have the right diagnosis, and then figuring out how to treat those kinds of things. NAMI specifically has a strong history of identifying the organicity in mental illness. I think that's a major new understanding, is that people's brains are organs that can be diseased or have illness as well, and so those are the things that can cause mental illness. However, as a psychologist, I'm not 100% convinced that all mental health problems are a result of an organic brain disease. There are situational factors still that can lead to anxiety, depression, and certainly behavioral treatments that can be effective for some of the less severe mental illnesses. Okay. This is for law enforcement folks, and I think we all need to recognize this, but mental illness is not a crime, and just because somebody's very psychotic, or even if someone is suicidal, or those kinds of things where we do need to sometimes involve law enforcement, there aren't criminal charges for having mental illness. Sometimes there are behavioral things that we have to impose upon folks when they get really ill. We have to be a little bit paternalistic. We try not to, and we want to respect individuals' rights as best we can, but sometimes mental illnesses are so disturbing and have people's thoughts so mixed up that people do have to step in and make decisions for them. Basically, this is just stating that there's a lot of folks who have mental illness, and mental illness comes in all kinds of degree, from social phobia, public speaking kinds of things, which is a very common mental illness, to major depression, which is also fairly common. Bipolar is less common. Schizophrenia, schizoaffective disorder, we'll talk about most of them. Sadly, because we are not treating folks effectively, there are a lot of folks that end up in institutions other than treatment facilities or in psychiatric hospitals when they probably wouldn't need to be. Do folks know where the largest number of mental health patients in any institutional setting? Does anybody know where that is?
Prison.
Prison.
Los Angeles County Jail has more and a higher population of mentally ill than any psychiatric facility in the country. And so it's kind of a sad thing, and I think we need to give more focus on mental illness and mental health and how to treat folks rather than just controlling and incarcerating. And if folks have major mental illnesses and don't get appropriate treatment, they do become vulnerable and they do make poor decisions and can get themselves into those legal settings where they're more likely to be abused again. Developmental disabilities, again, these are things that that kids are thought to be born with. And so mental retardation in all of its degree, autism, Asperger's disorder. Asperger's disorder is... we're becoming more aware of it. We never diagnosed it until 1984. It's a problem with social reciprocity. There's a lot of signs and symptoms. It's kind of a social awkwardness. Most kids with Asperger's disorder get really fixated on some subject matter, and they can be kind of experts in their area of interest, but they have a very hard time shifting topics, and they do those kinds of things. We have attention deficit disorder. There's quite a few things that come in the developmental disabilities. And then psychopaths and sociopaths. In mental illness, the diagnosis, we don't even actually have those as diagnoses, but we have antisocial personality disorder. And there are a lot of folks with antisocial personality disorder who are not psychopaths or sociopaths. We think that raises to another degree. And generally, those are folks that have little disregard for others, criminal kinds of behavior, those kinds of things. So the major mental illnesses, they list schizophrenia. Schizophrenia falls in the psychotic disorder realm. Psychosis is when people are not based in reality or their beliefs aren't in line with reality. And so we see delusions, and a delusion is a fixed false belief. And there are a wide range of types of delusions. And there are a lot of pretty functional folks out there that have some pretty serious delusional beliefs. But if it's not causing problems in their work life or other social functioning, it's still not even a disorder. And then there's the degrees. One of the hardest things we determine sometimes is religious delusions, because there's such a wide variety of normal religious belief. And then there's folks that kind of take it over the edge, so it becomes outside of the cultural norm expectation. And then hallucinations. Hallucinations are false interpretation of sensory information. And so people that are hearing voices, somebody talking to them, the radio talking to them, when it's not tactile hallucinations, visual hallucinations, and olfactory hallucinations. Olfactory are smell. And olfactory hallucinations, people should know, in general, are not highly related to mental illness. They are highly related to brain organicity. And so usually folks that are smelling things that aren't there should be medically assessed, MRIs, PET scans, those things should be conducted. We find that a high percentage of individuals with olfactory hallucinations have brain tumors and those kinds of things. And so it's a different thing to be looking for. Bipolar disorder is when individuals have significant mood fluctuation and have had to be diagnosed with a bipolar disorder. You've had to have a major depressive episode. And major depressive episodes are not just the blues, or not just a little bit down for a day or two. You have to be sad and seriously sad for a 2-week or longer period. It's usually not situationally related. It kind of comes out of the blue. People don't eat. People have problems, or they eat too much. They find that they have sleep disturbances where they're not sleeping or sleeping too much. Tearful, suicidal, all of those things are in the major depressive realm. The bipolar, the other polar end of that, is when individuals have hypomania or mania. And the difference between hypomania and mania is basically duration. Hypomania is 4 days or longer, and mania is a week or longer, of elevated mood, irritability, overly focused on goal-directed activities, acting outside their general personality, getting in trouble with irresponsible sexual behavior, speeding, just about anything that really gets over the top, and folks can't slow themselves down. You see a lot of pressured speech, that kind of stuff. Obsessive compulsive disorder is in the anxiety disorder realm, and so anxiety panic disorder. Obsessive compulsive disorder is individuals that get stuck in routine, and so checking things, counting things, arranging things. They just spend excessive amounts of time because they have some fear, hand washing with germ phobia. Folks have all kinds of beliefs and rituals that they kind of get into doing, hoarding behavior, things like that, that for some reason, or they have gotten it so that those behaviors reduce their anxiety a little bit. The problem is it doesn't resolve their anxiety, works against them, and becomes more problematic. Anxiety disorders, we've got a lot of them. We have panic attacks where people think they're having a heart attack, but they're not. I take a little sidebar out here and talk a little bit about the fight, flight, freeze response. I think that the fight, flight, freeze response is one of the most important things mental health people should know, and folks working with anyone who has a mental health problem. And so, throw out a few questions. What else do we call the fight, flight, freeze response? It's our sympathetic nervous system. Okay. Our sympathetic nervous system is active, and the reason they call it sympathetic is because we have sympathy to the stressor that's going on in our lives. And so it's called the sympathetic nervous system. And then there's another something that it's associated with in our nervous system. It's the involuntary nervous system. So it's the things that happen to us without us thinking about it. And so because knowing about it is so important and can be so helpful when you're working with someone, we're going to go over what happens quickly when people have an anxiety response. We can go to the next one. And I'm getting a little ahead of myself, but I want to do that right here, and then we can cover it again later, right, if we want to. And then we'll go back to the schizophrenia. So when I educate about the fight, flight, freeze response or the sympathetic nervous system response. I usually have people look in the corner and visualize that there's a mouse in the corner and that there's a cat about 2 or 3 feet away. And then I start trying to explain what is going on with the mouse. And so I start off with smell, because most animals, their primary sensory perception is smell. We human beings don't use our smell as much, but smell is still our primary sense memory. And so if you've smelled something before that had caused problems in your life, when you smell that again, your brain is more than likely going to go back to that event. But I don't talk a lot about smell because we don't use smell for that sense indicator. Most human beings use vision as their primary sense indicator. And so what happens with the mouse's eyes?
Really big. Yeah.
They get really big. Nobody ever closes their eyes when they think something is about to eat them. And our pupils get really big. And do our eyes fixate or do they shift? They shift because cats hunt in packs and because we look for escape routes. And so we're looking for light and darkness. The blood flow to our eye changes. Okay? The cones of our eyes get depleted of blood. The rods of our eyes get more blood because we are really aware of movement and black and white. So we can escape it, and if a cat comes towards us. So our eyes are open, we're processing black and white and movement. What happens with our breathing? It gets rapid and shallow. Rapid and shallow. Right. We hyperventilate. Hyper means we take in too much oxygen. And so if we breathe really rapid and shallow, we take in too much oxygen. If we just burst into running or fighting, we would use up the oxygen and we wouldn't hyperventilate. But most of the stressors we human beings experience are having some strange person come into our house, confront us about our finances, do whatever other folks do. But running up and hitting someone, running away, those kinds of behaviors aren't terribly helpful for us as humans. Okay? But we hyperventilate. They used to tell us to blow in a bag because then you blow out your carbon dioxide, you suck it back in, and you're out. But you get too much carbon dioxide. Blowing in a bag is not a really good idea. And so instead, we invoke our voluntary response, and we can take some nice, deep breaths, okay, and change that. When we breathe in, we should be breathing in through our nose, out through our mouth. Breathe in through your nose because it puts moisture into the air. Out through the mouth because animals that think they're going to be attacked tighten up in their jaw and their neck. And so your nostrils flare. And so if you just open your mouth a little bit, you feel a little more relaxed doing those kinds of things. And what's the major muscle that controls your breathing?
Diaphragm.
The diaphragm. And so that diaphragm is squeezing, which is putting a lot of pressure on your digestive system, and we'll talk about that in just a little bit. And what organ is most closely associated with your lungs?
Heart.
Your heart. And your heart does what? It pumps blood. Yeah, it's just simply a pump. And so it's picking up this liquid blood that has got too much oxygen in it. It's getting a little foamy, actually. It's not doing quite the job that it's supposed to do because we didn't burst into a run. And when our heart starts doing this whoosh, 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 as opposed to the nice long strokes, then the blood pumps differently. Okay? When it takes the nice long strokes, it pushes it all the way out. all the way out to the fingertips, all the way out to the surface of the skin, all the way out to the outside part of the brain. When it starts doing this I'm scared rapid beating, it goes to the primary organs, because you got to keep those alive. It goes to the old reptilian brain that controls some major muscle movement and keeps our organs functioning. And it goes to the big muscles, so I can push out. And so the parts of the body and brain that are being starved are the outer part of the brain that has impulse control. We don't need impulse control when we think something is going to jump on us and eat us. We need impulsivity. We need to be reactive. We aren't doing higher level math. This is really reactionary stuff. That part of our brain, our ability to think, just kind of gets depleted. We don't want blood on the surface area of our skin, because if we get cut, we will bleed out. And so the blood goes deep. And what happens with the muscles? Muscles tense up and they contract, okay, because that leaves us the ability to spring out, to fight, flight. Most people, animals, carry the majority of the muscle tension in their neck, upper back. Anybody that's old enough to have watched Wild Kingdom or any of the animals attack at the neck. And so you have to stabilize your head. You pull your shoulders up to protect your neck. We do that stuff without thinking. We get tense. And what happens to our digestive system? It kind of shuts down. It shuts down in our mouth because nobody stops to eat or drink something when they think so. And so our mouth gets dry. The saliva glands stop producing. The top part of our stomach here is getting squeezed terribly by that diaphragm. There's a little valve on the bottom of our esophagus, the hiatal valve. That is usually nice and round and gets sealed up really good. But when our diaphragm is squeezing and twisting, that isn't round anymore, and the gastric acid starts coming up in the back of our throat, and we feel it in our chest. The stuff in our stomach locks down because it can't really get it through fast enough to be of any good. If we have chronic stress, we get irritable bowel syndrome, we get all those kinds of things. And anybody that's ever given a speech has felt like they had to go to the bathroom just before they got up in front and talked to people, because our system has already utilized that and it's just waste. And so you'll see a little urine and feces under the mouse. Mm-hmm. And perspiration. What happens with perspiration?
Increases. Yeah.
It increases, but it increases for a different reason, because usually we sweat to dissipate heat. We're trying to get rid of all that heat. But our blood has gone into our organs and into our major muscles, and the heat is not on the surface area of the skin anyway, so we get the cold sweats. Researchers hypothesize that it makes us slippery, so we can run a little faster without chafing. We maybe can slide away from the predator that's after us. We're having all of those kinds of things. And so that happens with the fight, flight, freeze response, with the sympathetic nervous system, the involuntary nervous system. And the only reason it's really important to know those things is because we human beings have an outer layer to our brain that can override all of that involuntary stuff. Not all of it, but most of it. And so one of the things that we can do if we're feeling really stressed, or somebody we're watching is really stressed, is we can get them to sit down, okay, and elongate, so get comfortable.
Deep breaths.
Yeah. We can take some deep breaths. If they're comfortable enough with them, we can even coach them to close their eyes just for a little bit. We don't want to do that with somebody who's paranoid or not trusting of us, but close your eyes, take a nice deep breath, take the weight off your feet, take a drink of water, get your digestive system going again, okay, cool down. there's a lot of things that we know we can do, that we can use to control our own anxiety, and that we can also help other individuals with when they're feeling stressed. And so it's really important that we watch folks in an observant kind of way, not a staring kind of way, but in an observant kind of way, to say, is this person's eyes wide open, and are they shifting and unable to focus, and are they looking like they're really tense, and are they having a hard time breathing? And anxiety is one of those illnesses that people can have along with every other illness. And so it's sad, but with mental illness, they don't necessarily come with, you get this label and no others. I had a professor who was not very politically correct and said dogs can have both ticks and fleas. And people can have depression, schizophrenia, anxiety. Anxiety is something everybody has. And so we need to just be aware about anxiety and how to get folks relaxed so the blood goes to the outer part of their brain and they can engage with us and think. And familiarity makes people so they're less anxious. So the first time you meet with someone, they're likely to be way more anxious than down the road after they've gotten to know you just a little bit. Okay. So I wanted to cover that about anxiety and how it happens and kind of what we can do to be aware of and help with. And then I'm going to go back to the schizophrenia. And I want you to know, any questions at any time would be good. Schizophrenia is one of our most severe mental illnesses. It's the most disturbing in folks' life. The only one that's more severe, in my opinion, and most people would say, is schizoaffective disorder. If you hear of schizoaffective disorder, that means the person has both schizophrenia and a mood disorder. And there's two types of schizoaffective disorder. That is of the depression type and bipolar type. So some people have schizophrenia with major depression. Others have it with a bipolar. So they have both the manic and the depressed symptoms. When we talk about schizophrenia, most of us are aware of and think about the positive symptoms of schizophrenia. When I say positive symptoms, they're the things that are added to an individual that the person generally doesn't have or experience. Okay? And then we'll talk about negative symptoms in a little bit. But those are the positive symptoms that are listed. They are hearing voices, the hallucinations, they're fearful, they're paranoid, they have beliefs just not based in reality. Okay. And then the negative symptoms are the things that schizophrenia steals from people. It steals people's motivation for some reason. Clearly, if you're not based in reality, it's difficult to develop good, strong friendships and social supports. And the more severe and the longer it lasts, the less quality of relationships that people tend to have unless they have really good support groups and can manage those things. Folks with schizophrenia, they get so that their movements aren't fluid. They look like they're kind of robotic sometimes. The other thing is some of our medications cause those kind of robotic movements or muscle tightness or facial twitches and those kinds of things. We watch for something called tardive dyskinesia, where folks' tongues kind of twist and their muscles lock up. And that's not from the illness, that's from the medications that folks get. Those are the things that we see for folks with schizophrenia. You can see how that really would interfere with a person's ability to hold down good relationships, be functional at work. Most of the illnesses that we talk about are episodic to some degree. Schizophrenia is a chronic, persistent mental illness. However, the strength of the voices will sometimes go away. The delusional strength goes away. Usually when you talk to folks with schizophrenia, they'll say, no, they're always there, but I can ignore them, or I can recognize they're not real now. And then there are other times when they become so intrusive that they can't avoid them. Bipolar disorder, this is the one where you have major depression. Yes?
Excuse me. May I ask a question about schizophrenia before you go to the next? My
Sure.
question is, if you have a tendency to be schizophrenic anyway, things like additives, like the muscle strengthening stuff, and that kind of thing, can that tweak that to be it worse? Steroids is my word, I guess I couldn't think of.
Steroids have a tremendous impact on individuals' perceptions of pain, and individuals with schizophrenia, it can change their mood and can make them more stressed and certainly can exacerbate symptoms. When you talk about substances, specifically like steroids, there are certain steroids that are prescribed, there are non-prescription illegal steroids. It really makes a big difference on what types of medications or substances the individuals are having. But any change in routine can really cause individuals with major mental illnesses significant difficulty.
Second question.
I don't know if I answered your question.
Well, yes, you did. Yes, thank you. One more question, however. Now, I've heard that I have a brother who has been diagnosed schizophrenic and bipolar. Although the last year and a half to 2 years, he seemed to be symptom-free. Is this a cycle kind of thing, or he does not take medication?
He doesn't take any medication?
He refuses to take medication.
Okay. Certainly those illnesses cycle in their severity. And I can't speak specifically about any one individual. And we occasionally misdiagnose. We do the best we can, but we misdiagnose. Sometimes individuals, as they get older, some of that energy that they've had in the past that can promote more problematic behaviors dissipates a little bit, and we can see some lessening in symptoms. Stress always impacts, or almost always impacts, the severity of the illness. And some individuals who have schizophrenia under low stress, folks are giving them a little more space, being a little more understanding. Their symptoms can sometimes be pretty well managed for extended periods of time without medication. However, what we know about the illness is it's usually likely to cycle back. People should stay on maintenance levels of medication if they've had significant problems. And those are the things that we look for and do to make it so folks don't have reoccurrences of their illness.
Thank you very much.
Any other questions? I could talk a little bit about the medicines that we use to treat schizophrenia. And this is a little deep, but there's two major theories for schizophrenia. And the most common belief about schizophrenia is that it's caused because of the neurotransmitter dopamine. And too little dopamine in our system causes Parkinson's disease. Too much dopamine in our system causes us to hallucinate. We know that from people with Parkinson's disease, that we accidentally over-medicate. Now, their symptoms are a little bit different, but we know that. And then we treat most of those illnesses with dopamine agonistic medications. So it prevents the building or making or site binding of dopamine. There's another theory that isn't nearly as popular, but I believe probably more strongly than the dopamine theory, and that is that our brain has about as many neurons as we're ever going to have at birth. We get a few more for the first few months. But then after that, our brain starts becoming more organized, which means that we aren't using our whole brain to do every function. We start developing speech centers and hearing centers and vision centers and those kinds of things, and we call that neural pruning. And we know that the majority of pruning takes place by the time we're about 6 years old, but the process of pruning continues pretty significantly until we're about 20 years old. What we see with individuals with schizophrenia is that certain parts of their gray matter, I think it's their gray matter, disappear. And what I believe and what some researchers believe is that the thing that shuts off our brain so that it quits pruning and getting so that it's more compartmentalized doesn't stop with individuals with schizophrenia. And so their brain continues to work to get more and more organized. But once the area of the brain kind of is filled up with activity, then the neurons start looking someplace else to make connections and understand the stimulus. And that there are neurons then that reach out into other areas of the brain, and so your brain is stimulated by a vision, but instead you hear something. And there's more and more research about that, and that kind of would help us understand, because what we don't know is why, for most folks with schizophrenia, the symptom onset is around 19, 20 years old, and there's some correlation there that gives us some insight or possibly is happening. What it doesn't explain is why the medications we use work. And then the old medications were Haldol and Mellaril, and they were all dopamine medications. They all had really significant side effects with muscle rigidity, tardive dyskinesia. Then we came up with some new atypical medications, Clozaril, Risperidol, those kinds of medications. A little less side effect profile, but we're seeing now that we're using them more, they still have a lot of side effects. And so there are lots of reasons why the folks don't like taking the medications. Most people don't want to admit that they have a mental illness, and most people don't like the side effects of the medication that we use to treat them. And so they're difficult illnesses to deal with and to effectively treat. And then bipolar disorder, that was the high side. That's when you see people with pressured speech, irritability, some aggressiveness, all of those kinds of things. And major depression is what we talked about a little bit before, but you see the sleep disturbances, appetite changes, hopelessness, helplessness, thoughts of death, suicide, self-harming kinds of behavior. OCD I talked a little bit about before. It's the basal ganglia is the place where most of the switching in our brain is done. And so what we think with obsessive compulsive disorder is that it's like a switch that keeps getting accidentally turned on and off and on and off and on and off. And so the person just keeps having this kind of repetitive pattern. Anxiety, panic disorder. We see a lot of folks with anxiety, panic attacks. Panic attacks are that fight, flight, freeze response. Most folks are going to the hospital thinking they're having a heart attack with those kinds of things. The difficulty is if you have asthma, if you have a heart condition, you can still have a panic attack, and it's really hard to sort those kinds of things out. And sometimes people are having panic attacks because they have asthma or they have a heart condition, and it starts kind of a repetitive cycle for them. This is just something that everybody should know. South Dakota also has a Good Samaritan laws and also the right and responsibility to help if folks are potentially harmful to themselves or others, and to take some kind of action or step. we in mental health, actually anybody over the age of 18 can complete a mental illness petition if you think someone has a mental illness and is dangerous to himself or others. And that dangerousness includes threats or actual acts towards somebody else, threats or actual acts towards self, or inability to care. It means they can't feed themselves, don't have appropriate housing because of a mental illness, committing some kind of criminal act due to their mental illness. I want to talk about another mental illness that I don't think is covered in the presentation just a little bit, or a group of mental illnesses. And the group that I'm going to talk about is often hard for folks to talk about. It's the personality disorder groups. And the reason that it's hard to talk about is because we know even less about them. And we have really less ability to treat them. There are all kinds of different personality disorder diagnoses. There's obsessive compulsive personality disorder, there's dependent, there's avoidant personality disorder, there's narcissistic personality disorder, there's borderline personality, paranoid personality. We've got a lot of different kinds of personality characteristics. We tend to be a little more understanding of some than others. Antisocial kind of gets kicked just right out because that's criminal behavior. However, we're having a lot of research that says that folks who are antisocial are born with their brains functioning differently, and a lot of folks have had some attention deficit hyperactivity disorder and other kinds of mental health problems that lead to them getting into conduct disorder and antisocial. And it's hard to know at what stance, where we take the exact stance in saying this individual is not somebody who's ill, this individual is somebody who is bad. We get into borderline personality disorder. That's one of the most common or familiar, I think, diagnoses. And it's one that's the most often probably misdiagnosed and diagnosed as something else. The reason it's called borderline personality disorder is because it's borderline everything else. It kind of seems like the person's depressed. It kind of seems like the person has manic episodes. It's at times the person has post-traumatic stress disorder, and sometimes they dissociate. And we just see all kinds of unusual borderline, but it isn't quite that. We tend to be a little more understanding, but not a lot more understanding with that illness. We are much less likely to send individuals with borderline personality disorder to jail for their behaviors, but we don't usually have much patience for them either. We see a lot of self-harming kinds of behavior. Our research is getting pretty clear that their brains, too, early in life, are hypersensitive to emotional dysregulation. Usually they have some invalidating life experience, or more than the average person does, which kind of makes sense, and you can do that without blaming the parent, I think, because if you have a child that is very reactive to every kind of emotional or physical experience they have, parents tend to tell them, stop it, you're not that sick, and then we invalidate their experience, and you get into a cyclical pattern of poor interaction, not good, productive behaviors. We see a lot of self-harm kinds of things, cutting, burning of self, those kinds of things with the borderline personality disorder. The research is really good on validating folks' emotions, and it doesn't matter if they have borderline personality disorder or any other mental illness. Validating is always an important thing to do. I could talk a long time about motivational interviewing. It's something that was developed about 20 years ago. But motivational interviewing is basically rolling with the person's resistance. And so when you come up against them not seeing things the same way you see them, rather than butting heads with someone, you agree with what you can agree with, and you slightly shift into a direction so that you can make progress again. And that communication, even with healthy, normal folks, is something that we need to think about and utilize when we're trying to interact and get folks to do things that we think would be good for them or to work better with us.
Do you have any suggestions on the narcissistic personality disorder? Particularly, we're looking at employment, finding it very hard for them to accept direction from someone else because, of course, they know how to do it better and all that. So, any...
Narcissistic personality disorder is a really difficult disorder to treat. We don't have any medicines that help with narcissistic personality disorder. The term, for those who aren't familiar, come with the Greek myth of Narcissus, who was the most handsome young Greek who looked into the clear pool of water and saw his reflection and was so enamored by what he saw that he kept leaning over until he drowned. And so that's where narcissistic personality comes from, is folks who know everything and know more about everything than anyone on every subject. And those folks are a little challenging to work with and get placed. I think that it's important to get them with a therapist. Okay. I think it's important that you got a release of information signed so the therapist can speak with the people who are working with them, because if you confront someone with borderline personality disorder, narcissistic personality disorder, paranoid, if you confront them, they will resist you. And so therapists aren't very successful in, this is what you have, this is what you need to change. But we can be pretty successful with, this is what your vocational rehabilitation services worker is reporting about you on your job site. And can you talk to us about that and how that's working and what you would do a little differently? Getting third-party folks involved can be tremendously helpful, and we can help kind of negotiate the course a little bit. I'm a little optimistic there, but most of us therapists are a little narcissistic too. Anybody that thinks they might be able to intervene in someone else's life and help them out has got a few issues of their own. And so, but it's a good question. I do think reading about communication styles and that motivational interviewing techniques can be really helpful, because those techniques empower the individual and they start letting the person be able to kind of pick and choose a course for themselves. The other thing is, most of us believe that people with narcissistic personality disorders also have a tremendous narcissistic wound. That means that somewhere along the line they have been hurt, or they're protecting something. And so they're trying to prove to everyone how smart they are and how capable they are. And they're awfully sensitive to rejection or correction. And so validate, give praise as often as you can. The average person needs about 8 positive statements for every negative statement. People with narcissistic personality disorder, probably 30 for every. Yeah. And so always focus on people's strengths.
Question.
You can go back. I didn't.
I got a question regarding narcissism. Is that environment, or is it genetic?
Yes.
Both?
We don't know. what I think most scientists, practitioner, researcher types would say is we can't sort it all out. We can argue both sides. Clearly, human beings are biological machines, and we take in amino acids and we take in other forms of nutrition, and we metabolize it and we utilize it, and clearly how we're doing all of that. And we know of well over 100 different neurotransmitters. We play with about 5 or 6 of them is all that we really affect with our medical treatments. It's what I started off the presentation with is the things that we deal with in psychology and psychiatry. There's a lot of speculation, but not a lot of really hard science. For most personality disorder kinds of things, we think there's some genetic predisposition, and then we think there are environmental factors.
Sorry, we're making sure everybody's
Is
still
everybody
on.
connected?
We
Yeah.
lost the picture.
Okay.
And we think there are environmental factors. How that is all sorted out, we still don't know.
Just out of curiosity, would it have anything to do with, you know, so some studies show birth order has something to do with different mental illnesses? Have you ever heard of like maybe birth order having to do with any narcissism? Like how they...
Alfred Adler was one of the first birth order social scientists, and there's been a lot written about birth order, and some of our birth order studies hold true when we stay strictly with families 3 and under, children 3 siblings or under. Once we start getting more siblings involved, the research really kind of falls apart. There's a lot of people that would argue, you know, that the oldest child is the caretaker and maybe a little bit more on the narcissistic side. There's people that would argue the youngest child is narcissistic, and then there are some people that would say, well, the middle child, they were the ones that got the least attention, and so they're most narcissistic. I don't think our research really supports it very strongly.
Do you think a narcissistic parent can have a narcissistic child?
I do. No. I think that you can. But again, it doesn't lend a lot of argument to if it's biology or if it's environment. Mostly, when we talk about personalities, we think that there's some predisposition of the child, and then the parent has responded in a way that has kind of brought out more of the difficulty than relieving the difficulty. But again, we have a tendency to blame patients and to blame parents and to try to make explanations for things that we really don't know about. And we human beings have a really hard time with saying, I just don't know. And the truth is, we just don't know. I think. Just some basic things when we're working with individuals, empower them. Okay, and so if you're seeing someone that is feeling, that it looks like to you that they're feeling anxious or threatened or anything like that, ask them what would make them more comfortable. It's one of the things that they have to teach us in psychology really early on, and then they have to keep teaching it to us. If we have a question from somebody, what's the best way to get the answer?
Okay, so if
If we have a question about an individual that we're working with,
right,
what's the best way to get an answer?
you ask them.
Ask them. Right. We tend not to do that as often as would be helpful. We start looking for reasons and justification and defensive positioning, and we do a lot of things rather than what is it that I can do to make this better for you? And that's usually a pretty helpful place to start. And if the person thinks that you care about them and want to be helpful, you've probably got your best shot.
Do you see that it is easier to impact someone with a personality disorder, any one of the gamut, as you reach them when they're younger than 45, 50 years old? Are you going to make much of an impact by that time?
I think time is always on our side, but again, that's just an optimistic me. And so one is we don't diagnose personality disorders before people are 18 years old, because prior to 18, you've got a lot of behaviors that just aren't stabilized and your personality isn't fully set. And so, and then clearly the younger we are, the more time we have, the more hopeful we can be. And I think that in our professions, it's best to be hopeful. And if we are hopeful with an individual and we express that hope, it empowers us in our relationship. Just good communication skills. Too often, as I'm doing here today, we talk too much. And so, especially with an individual that's having problems with being right in the here and now, with knowing if they're in reality or they're hearing voices or they're anxious, is go slow, give them time, be respectful. I'm really open for questions mostly. You folks all can read.
Do you think personality disorders are under or over diagnosed at this point?
Accuracy in diagnosis is really, really difficult to narrow down. You know, we randomly test people with questionnaires and those kinds of things. I think it really depends on clinicians and individual clinicians. But then I think we as clinicians are also kind of set up so that it's hard to study us too and what we do. Because if right now I don't know any doctors in Yankton that are specializing in attention deficit hyperactivity disorder. But if you came to Yankton and said, I specialize in attention deficit hyperactivity disorder, every child that was suspected of having attention deficit hyperactivity disorder would be referred to you. And the ones that you didn't diagnose, their parents would be upset with you because I wanted an answer and you're not giving me one. And so people get to be specialists and then they get those kinds of cases referred to them, and it's really difficult. I think most over it's not really helpful to be diagnosing folks. I think there are definite advantages to it, especially schizophrenia, bipolar disorder. Bipolar disorder is our strongest biologically linked disorder. If one identical twin has bipolar, the other one has a 70% chance of having bipolar. And it's really only managed with medication, mood stabilizing medication. Therapy helps, but you need the medication. Schizophrenia, if one identical twin has it, it's a 50% likelihood that the other one will have it. So we're not getting a strong biological, but it's major depression is like 25, 30% if it's identical twin has it. And then personality disorders are in a realm all to themselves. We know when we're working with somebody with a difficult personality if they're diagnosed or not. And the real question is, what do I do to make this situation better? Okay. Too often, I think, we use the label as an excuse. they've got borderline personality disorder, no one can help them. Right. And we still have a responsibility to try to help. And so I think we're better off not diagnosing in those situations and talking about what is going on in the here and now with the individual. And so you seem like you're having a hard time breathing, relaxing. Can you sit down? Would you like a glass of water? It's hard for me to listen when you talk that fast. Can you slow down for me? Yeah. Truthfully, punishment doesn't work even for criminals. Punishment only works if you're standing right next to the person and you've got a bigger weapon than they have. And so try to avoid getting into power plays with anybody. It just doesn't help. Don't reinforce psychotic behavior, and there's no point in arguing with the delusion or hallucination. If they're feeling it, thinking it, seeing it, it's real to them. Shift topic areas, get them comfortable and relaxed, find out if they're fearful, do the things to get the person so they're as functional as they can be. And we'll talk a little bit more about petitions and mental health referrals at the end. And too intensive observation is upsetting to folks. The cat, when it sees the mouse, is staring. Usually 1-to-1 is the best. Makes it so that we can look at each other. We aren't getting a lot of other information. Do what you say you're going to do. Don't say you're going to do things you aren't going to do. Touch is one of those things that's very difficult. Generally, the rule of thumb is avoid touching. However, touch can be very therapeutic and calming at times, but it's a lot easier to defend yourself if someone accuses you of not touching them than touching them. Again, when people are having a very difficult time communicating and their thinking is somewhat confused, open-ended questions are a little too much for them to deal with. And so go back to asking yes, no kinds of questions, giving multiple choice options, and then vary your communication style so that they remain effective. Okay, so if you ask an open-ended question and the person shuts down and feels overwhelmed, back off, give them another question that they can answer. Folks with perceptual distortions, paranoia, they are going to interpret whispering, joking, laughing. Actually, most of us do. If somebody is whispering, laughing, joking around us and we're not included, we wonder, is it us? Yeah. Okay. And again, honesty is really important in all relationships. Things you can ask. I don't know how you guys do your initial intakes when you get it. I think that it's important to have routine, and so it isn't out of the blue that I'm asking what medications are you on and are you taking them. And so, and then also if it is going to be routine, if you find someone you're working with, then make sure that it stays routine. So, and explain to them. I know that you have an illness. I know you take these medications. I know these medications seem to make you function a little better, or that's the goal of those medications. Have you been taking them? How are they affecting you? You think they're working with you? Have you been talking to your doctor, your case manager, your counselor, those kinds of things? Hurting yourself, committing suicide, wanting to hurt someone. Again, I don't know if that's in a routine kind of way. The best way, though, is to just ask straight up in a caring way. Okay? And I think it's important for everyone to know when they're in over their head. And we as mental health care professionals need to know when we're in over our head. And that's when you get consultation and you go and you make sure you talk to some other mental health care providers, you get other folks involved. And so when you're hearing information that somebody's thinking about hurting themselves, hurting others, probably be good to stay with that person if you feel safe until you get someone else involved that can manage that and make sure they're safe. And there's a lot of ways to get folks involved. The first key to safety, I think, is your safety. You can't help someone if you're not safe. And so if you're with someone and not feeling safe, as politely as you can, get some distance and then get other folks involved that can provide you with the support that's needed. Okay? Throughout the state of South Dakota, my experience is law enforcement is generally very good. They have pretty good training. They aren't rushing in with sirens blaring, and they know the system of how to get folks help. And clearly all the community mental health centers, emergency rooms at the hospitals, there's lots of folks to call if you need some assistance. Some of the statements on here seem to me to go without saying, but
I had a question. This
Yes.
is Carmen in Huron. If you're
Yes,
dealing
Carmen?
with somebody, if you're dealing with somebody that you don't think is safe or is threatening to harm others, is it best to first call the police or first call the emergency room or?
Okay. It's really hard to train that, and I do think that people have to go with their gut. Okay, if you have a person that's not safe with you, it depends how they're not safe. If they're saying, yeah, I can talk to you, and it's okay for you to call the emergency room of the hospital, then I would stay with them and do that and see if I can assist them into getting the care that they need. But if they're saying they're not safe and can't make you safe or you don't feel safe, then I think it's important that is it okay if I talk to someone, or I need to talk to someone? You need to make sure you're safe first. And then it's important to realize that the only person that can actually force someone into treatment is a law enforcement officer. Okay? They're the only ones that can really apprehend, take someone in on a hold. The emergency room isn't going to come out and get them. The EMTs don't want to come out and get them without law enforcement. Sometimes you have to coordinate and get both of them there, but your 911 person will help you with that and will ask you some good questions. I think that's just, it's hard to know. I think if they have a rapport with you, if they're talking to you, if they can ensure some safety, find out who their providers are. It's always good to start, if you think you've got the time, with who's already been involved with this individual, who do they feel safe with. It's good, I think, if you find out someone has a mental illness, if you get releases of information signed so that you have the ability to talk to their providers and know what's going on, share information. And we as healthcare providers really want to know that. A lot of times you have way more information looking at the individual than we have. So I wish I could just say this is the protocol, but it really does depend on each situation. Keep yourself safe. Use your gut. If you call 911, they will ask you what's going on, and you can sort out how much of an emergency this is with that person too. I think you can also call your community mental health centers, but don't call us if you have somebody that's got a knife and they're got it against their wrist. You need to call 911 and get emergency responders there. Again, it's using the term defendant because this was made for law enforcement folks. It's important, I think, for you folks to know if there's a power of attorney involved or a guardian involved. If there's a guardian involved, the person can't make decisions by themselves. If there's a power of attorney involved, you should at least be consulting with the individual if they want that person involved in any kind of decision making. Again, everybody needs to have their basic needs. This is law enforcement kinds of stuff. Good interview practices, not to have a lot of people. People feel overwhelmed too often. This is just a side note, but we've gotten so that when we interview folks for jobs anymore, we have 4 interviewers with an interviewee. And oh my, that just seems to be confusing and stressful. And just imagine if you were a person with a mental health problem and you were trying to talk to 2 or 3 people. Again, just because somebody has a delusion or a hallucination might not be based in reality on 1 or 2 topics, doesn't mean that they can't give you lots of good and relevant information. And so sometimes you have to sort through some of that. Get people to relax. Relaxing is sitting down, not standing up. Very few people hit other people when they're sitting down. So if you can have the person sit down, if you can get them to have a drink, just the breathing, the relaxing, I'm just going to give you some time to kind of get yourself relaxed, composed, encouraging that kind of behavior. Okay. This is a really important interview technique. Primarily, I think it's for clinicians and not for you folks. But sometimes individuals that are bipolar or personality disordered, their speech comes so fast that it just rambles on, becomes what we call tangential or circumstantial. Tangential, it just goes off and never comes back. Circumstantial is you ask them a question that a few sentences should answer and they're still talking to you a half an hour later. Sometimes it's not best for us to be overly polite. And you have to move people on in their conversation. And in our business world, people expect that. And sometimes I think we're crunched for time. And so we need to kind of get things done. So it's good to let people know. I'm sorry, but I only have a half hour, 45 minutes, an hour with you. I have a lot of information that I'm going to need to cover. I'm sorry that I have to interrupt, but I need to get you back on track, do those kinds of things. I should have said that differently either. I need to get myself back on track. Take the responsibility rather than saying that somebody else is off track.
David, how do you deal with this in terms of with employers and stuff? It's often good to give our employers advice and recommendations on how to deal with individuals as well, and they don't always do it very well, obviously. And do you have any advice in terms of what we should and shouldn't share with employers and giving them some tools to how to better effectively work with their employees?
Sure. I think it's always best for us to be as close to the here and now as possible. And I don't know what your limitations or abilities are in this is a diagnosis, And some, depending on the employer, some are very educated in the realm of mental illness and are very understanding. Others don't know much about that. And so depends what your relationship is, what the person already knows. I don't know how easily you guys can share.
And if you have a signed release.
Right, diagnoses. So I think that the safest and best thing is the person that I'm helping, your client, is having some difficulties in this area. Okay. They told me that this is what's happening. Not you did it. We don't blame. But they told me this is happening in their work experience. And I'm wondering if there's anything we could do differently. Open the door for the employer to give some kind of idea. And then if you've got good guidance information after you've elicited their response, this has worked well for me in the past with individuals who have struggled with this. You suppose we could try that, try to help negotiate. It's just all basic communication stuff. Yeah. And diagnoses, I think we get way too sophisticated, and we start throwing around diagnoses and labels, and it gets really confusing, and so here and now stuff. There's some, at certain conventions, of course, it's the conventions I go to, but they let people do virtual reality. I don't know if anybody's had that experience, but they have little helmets that you can put on that have little speakers in them, and it's like one ear is hearing something and another ear is hearing something, and if you ever get an experience to do just some simulated, my senses aren't just always interpreting the information, just do one of those for a couple minutes and you'll have a much greater appreciation for somebody who is experiencing schizophrenia, schizoaffective, other psychotic kinds of symptoms. It's really, really distracting and annoying, and I would be irritated too if I was having to live with that. Again, this is for law enforcement stuff. I don't know how often you need to do that. I think if you're aware, and it's good to kind of work into conversation. I also think, most of the people that are out there with anxiety disorders and depression never get treated. And so more than likely they haven't gotten a diagnosis yet. And so you're probably the first one to maybe even say to them, I don't mean to be insulting, but have you talked to your primary care doc about what's going on? And primary care docs are a great resource to find out if somebody's got anxiety or depression. Or, I've worked with quite a few folks in the field, and some of the stuff you're experiencing sounds a little bit like anxiety or depression. Or would you be willing to see a mental health care provider to see if that makes things better? If we can make some things better for you, that's what we're trying to do. So figure out ways to make that nice, smooth referral. We already talked about these kinds of things. It's good to be politically correct. Sometimes it's really good to be authentic, too. And if you're being too authentic and not politically correct enough, someone will tell you.
This is Carmen from Hearing again. And I got another question in regards to harming others. I often see statements where it will say something like, person denies homicidal ideations or whatever. Do people really say, yeah, I want to go and I'm taking my gun out and I'm going to go kill my neighbor? I mean, are they that honest?
Yes.
Would you?
Not everybody is, but truthfully, most people are. Most people do not want to be paranoid, afraid. Most people don't want to hurt other people. They don't really want to hurt themselves. They don't know how else to cope. Even the people that self-harm, people we tend to think of with like borderline personality disorder, and not all borderline personality disorders self-harm, and not everybody who self-harms is borderline personality disorder. But there's really good theory out there about why folks do that, and it's because of this fight, flight, freeze response. And we have known for centuries that bloodletting somehow pushes the adrenaline release over the top and lets people relax. It's probably the only reason that for hundreds of years they thought bloodletting actually helped people. It doesn't. It kills people, but we feel better. And what they know is that release lets them let down. Okay? And so there are a lot of people that, I had 3 people that came into my office last week. One who said, yes, I intentionally have thoughts of killing my neighbor, and I have a plan. I had a couple people who came in and said, I am having thoughts of killing myself, and I can't get rid of those, and I'm seriously thinking I'm going to do it. And that's, you need mental health professionals to ask a whole lot more questions and hopefully be able to get people treatment that they are willing to agree to. But there are times when individuals are ill enough that we do have to be paternalistic, and we take action to make sure that they don't do something that makes it so we can't help. And we can't help dead people. And people do. It's amazing how if you act like you care, people will tell you, and hopefully you do care. If you act like you care and you do care, people will tell you what they're thinking and what they're feeling. And once in a while, those people don't ask anybody, and then we hear about them in the news. Yeah. But it's rare. It's pretty rare. Any other questions? I'll go over the petition process real quickly, if that's okay. If you have somebody that you believe is a danger to themselves or others, in the state of South Dakota, you can complete a mental illness petition. And you can do that by calling law enforcement or a community mental health center or going to an emergency room. Law enforcement officers can place someone on a hold just because, basically. If you look like you're behaving strangely and maybe can't care for yourself, law enforcement can just stop and say, you have to come with me, and they can bring you into the mental health center. They have to complete out a lot of paperwork after they've done that, but they can do that just to bring someone in for evaluation. Otherwise, we can't do that. Just average person on the street. We have to complete a mental illness petition, and it's a specific form laid out in the state statute, and the form needs to know what county the individual is in that you're looking for, and it's helpful if you have other information so that when law enforcement looks for them, they can find them. But it's really a brief little statement. It says your name on the top of it, actually the client's name on the very top, then it says, I believe, and then you write your name in there, that this person is a danger to himself or others because, and then on that section you have to simply write because they're suicidal, they're thinking of hurting themselves, they have an inability to care for themselves, or they're thinking of hurting someone else. So just any one of those 4 statements, and then the evidence that I have to support this, and then you write that they told you. Now, you have to have first-hand knowledge. You can't be saying somebody else told me, and then once you complete that, you have to take it to law enforcement or emergency room or community mental health center, and all of those places have this form. If you don't have one otherwise, which you wouldn't probably, but you can come, you can complete one. Then you have to call it into the chairperson of the Board of Mental Illness, And then the chairperson of the Board of Mental Illness decides if that's enough evidence to initiate a mental illness hold. And if it is enough information to initiate a mental illness hold, then the chairperson of the Board of Mental Illness notifies law enforcement, and they can go place the person on a hold. They're not arrested, not charged with anything. It's just they have the legal authority to bring them in to an emergency room or a community mental health center for evaluation to find out if the individual has a mental illness diagnosis and if there's sufficient evidence to say they're dangerous and that they need to be held, basically sent to a hospital. That's kind of what you do in emergency situations. I think it's better to be safe than sorry, but you want to be respectful. And
What about a family member that comes to you and says, you know, I know about this, I know you're working with Johnny, and Johnny's been behaving this way and stuff, I'm concerned about him, what do I do, kinds of stuff. Often I'm referring, you know, to law enforcement, sheriff's department, things like that too, but
if you have immediate dangerousness, then I think you got to get law enforcement involved immediately. If you don't think that it's an immediate dangerousness, I really recommend that you send the person or refer the person to the community mental health center. And most, if not all, of the community mental health centers provide free consultation. And so if a family member is having difficulties and they want to talk to a social worker or a drug and alcohol provider or a psychologist, we make someone available to hear their issues and talk to them about what's the best way to get help for their family member. And we can educate them about this emergency process as well. If the person is in true emergency, then you need to say, you have really important information and you have to share that with either the community mental health center or law enforcement. And how can I get you in touch with them? Okay. Is it okay if I call law enforcement to come out to have that completed, or can we get you in? And then follow up. Yeah. If you're seeing something that concerns you that deeply, make sure you don't just give the information and then let it go. Make sure you follow up.
I've driven them to the center before in years past.
Yeah.
Tom would just take time, say, yeah, I think this is okay, or yeah, we need to do something. So.
No, at the community mental health centers, while we're pretty busy and we're underfunded, just like you guys are, there will always be somebody there to evaluate for emergency stuff. If you have questions about if the person has really had a significant change in behavior, and so that it's drug-induced possibly, or they could be having a stroke, or there's those kinds of things are best dealt with at the emergency room of the hospital. We would rather actually have panic attacks, because you can't diagnose a panic attack unless you've had a lot of skill, and get those folks to the emergency room of the hospital. The emergency room doctor will do the evaluation, make sure they're not having a heart attack, and they'll schedule them with us. Okay. Any other questions? I'm Dr. David Dracy. I work at Lewis & Clark. My phone number is 665-4606. If you have any questions or concerns, don't hesitate to give me a call. I'll talk to you and help you out or answer any questions. Okay?
I'd like to say thank you very much for being here. Yeah.
Thank you.
Dr. Dracy, this is Bernie Grimmy. I think it's very helpful. Good presentation today. Thank you.
Thank you. Anybody need any cards?
Thanks, everyone.